right, we'll go ahead and get started. Thank you for joining us. And I'm Rais Vohra. I'm the interim health officer for the Department of Public Health. I'll go ahead and share my screen so that we can all see what our updates are for this week. And hopefully we have Joe Prado and Dan Lynch on as well to help with fleshing out some of the other stuff that we've been doing here at the health department. So as you can imagine, a big week for COVID and kids getting their shots. So we'll definitely talk about that. But I'll start out with the numbers at first, just to share with what's going on in the county. As you can see, we're not the highest or even the second highest in terms of confirmed cases in the county. However, as of earlier this week, we really can't say that we are on the downward trend of any surge. So this last fall surge, which we know was extremely challenging, and it's almost deceptive just because it felt so much harder than what this curve reflects for a number of different reasons. However, even those numbers are no longer going down and they're actually starting to come up in the community. So that's extremely concerning. The next slide shows what's going on in our hospitals. And so this is another just big red flag because here we see non-ICU patients that are admitted to the hospitals and then ICU patients. The ICU patients seem to have leveled off. However, the non-ICU patients, they were coming down and now they're going back up. A little bit more granular information from the state on this slide, which shows that in contrast to our community transmission, we're actually number 2, right behind the People's Republic of Los Angeles in terms of the number of positive patients that we have in our hospitals. We've gone up to above 300 now. We're at 327. So you can see that we are really just pushing almost the peak of what we had in this last surge. And so, you know, in contrast to what I think everybody was looking forward to was a denouement through the fall until the winter surge starts. I don't know that we're going to get that. I think it's just going to continue at a very high plateau and possibly rise once again to that fall surge level. ICU numbers are leveling off a little bit, which I think is a little fortunate. It obviously, you know, speaks to the fact that these patients perhaps are not being admitted to the ICU. But, you know, all of these numbers don't tell the whole story. And I think all of us need to recognize that. First of all, they don't tell just how busy the hospitals are with non-COVID traffic. They're just super impacted. You probably all saw that Coia Delta had to declare a code triage last night. All of our hospitals are extremely impacted. We've actually restarted the assess and refer policy across several counties, which means that non-emergent calls to EMS will not get transported to the emergency department. We're having lots of meetings with our hospital partners to see how we can support them. So, you know, I think everyone should know that this is a really just hard time, and this does not bode well for the winter months for us. I'm going to advance my slides here. Are there any questions about that? I think tangential to that, but definitely related, is this concept of monoclonal antibodies. So, you know, I think we really do need to expand the number of providers that are giving monoclonal antibodies and just the number of patients and hours that are being spent doing this, because this is another chance for us to really help disimpact hospitals. This new monoclonal antibody treatment advisory came out just late last week. And this basically adds one more site, which is the Madera Community Hospital site, and also clarifies this new formulation of MAB, which is the sotrovimab. It's now also available for ordering. And if Dr. Zweifler is on, you know, he can speak more to this if you have any specific questions. But when we send out the notes, we're going to hyperlink to all of these different advisories that we're sharing. And that really brings us to vaccines. You know, obviously, we still want to push what I consider the primary vaccine schedule for those that are unvaccinated. They need to go ahead and get their vaccines ASAP, just because that will eventually help. It's not going to help right away, But, even if we start today to do an aggressive push, hopefully it will spare us the worst of the winter months. But we really just need to continue to have these conversations with our patients and really meet them where they are, see what their anxieties and concerns are, and really convince them that the only way through this pandemic, and I definitely believe that, is with these vaccinations. For those who need boosters, we definitely need to remind people that they should get their booster. There's a lot of confusion about which booster to get and who needs a booster. And really anyone that's at higher risk, just because of their occupation, because of their age, or because of comorbid conditions, including basic stuff like cardiovascular disease, diabetes, obesity, should be very strongly recommended to get a booster shot if it's been 6 months since their Pfizer or Moderna shot, or only 2 months since their Johnson & Johnson shot. And they can get any brand of vaccine for their booster. It really doesn't matter. Whichever one is first available is the one that they should go for. Now, the big news that happened this week is that vaccines for 5 to 11 years old were actually approved. And in fact, our local providers are giving them, which is a really exciting time for parents and families, because it just means that we're going to be able to protect that, it's about 10% of our population statewide. So we're going to be able to protect all those kids with these vaccines. I'll see if Joe wants to do a vaccine update before I move on to non-COVID news. Any updates on that, Joe?
Dr. Vohra, I think Joe hasn't had a chance to hop on yet, but I'll give him.
Okay. Oh, got you. Okay. Well, whenever he does pop on, we will go ahead and update and go from there. Is Dan Lynch on? Does Dan want to talk about what's going on at the hospitals? Okay, well, we'll just keep going with some of my non-COVID updates and hopefully loop back with them, or open up the conversation if people have any other questions or anything else that they want to talk about. So let me find my slides again. Okay, so we have a couple more advisories that we wanted to share with you and draw your attention to. One of them is this Botulism Advisory. And the Botulism Advisory really just speaks to the fact that we've had a couple of close calls related to botulism. As you may recall from your training, there's different types of botulism, including a type that affects babies that are given things like honey and other foods that contain botulism spores. The most common type of botulism that we see in California is the wound botulism that's related to IV drug use. There's also foodborne and iatrogenic botulism, and then adult intestinal toxemia, just related to people that have intestine overgrowth and bacterial problems. But it's really the infant and the wound botulism that we see most commonly. And unfortunately, we don't hear about these until there's a delay or until the state tells us that there's a botulism case. The reason that that's a problem is because it's really the task of the local health department to do a really thorough investigation to find the source of the botulism. And our staff can't really start that until they get alerted. So it's really up to the providers to alert the public health staff as soon as you suspect it. You don't have to get any labs. You don't have to get any specific testing. If you just suspect it in the clinical setting, that botulism is in your differential diagnosis, please give us a call. We have a lot of experts that have seen a lot of botulism that can help you work through the diagnosis, help you order the right tests, and then obviously help you track down the antitoxin if that's needed. But all of that can only be done if you do the reporting. So that's why it's a requirement under state law. And we just put out this advisory to really remind everyone about what to do and what the rules are. So look for that advisory on our medical providers page, and let us know if you have any questions. We put out another advisory about a new infection called CRAB. So this is not something that all of us probably learned about in our training because it's relatively new, but this stands for carbapenem-resistant Acinetobacter baumannii. And I've asked Dr. Al to give us a really good deep dive into this infection and what crab means and the implications for healthcare facilities. But this scares him more than COVID, actually. And this is something that he feels very passionate about controlling, just because we've had about a dozen cases here in Fresno County related to healthcare facilities. It's extremely hard to eradicate, and it really is one of those healthcare nightmares that we need to all work together as a community. What seems to happen is that people can get transferred, and then this diagnosis of crab doesn't follow the patient, and then there's a huge contamination issue at the next facility. So this is something that seems to be entirely preventable with good communication. And obviously, we don't expect everyone to be an infectious disease expert, but we do want you to be aware of this really scary infection, do the contact precautions that are needed for it, and then just be in good communication with each other as these patients cross facilities like skilled nursing facilities to hospitals and back again. I've asked Dr. Al to actually come on to our medical providers updates in the future, hopefully as early as next week, to do a deeper dive into crab. But right now the advisory is out. So please look at that. And if you have any questions, tune in next week for his presentation. And lastly, we have a big problem with syphilis. So this is another very preventable infection, sexually transmitted disease, but it can become a chronic illness with just a lot of complications, including congenital syphilis. And Fresno seems to be a hotspot for congenital syphilis. And there was actually an NPR and a ProPublica story about this, where they featured one of our communicable disease investigators, Mai Yang, in this article. And it's just all about, Mai's very valiant efforts to track down pregnant women with syphilis and get them the care that they need through a system that just seems to be not very responsive to these very vulnerable patients. So it's really well done. I think it really outlines, some of the limitations, but also some of the opportunities that we have at Public Health to work with our medical providers. We expect all of you to, certainly screen pregnant women and women of childbearing age for STIs, and definitely be aggressive about treating syphilis. And just a really nice story in NPR that just aired this week that shares more details about this dimension of syphilis, which is the congenital syphilis story. And with that, I don't know if Dr. Birnbaum is on and ready to discuss, but he actually had a really great case of neurosyphilis. I don't want to steal your thunder. Sorry if this was supposed to be like an unknown case, but I wanted you to discuss a little bit about your clinical case that you had recently, because I think it's very germane to this discussion.
Thank you very much. Hopefully you can hear me. Actually, my neurology service was asked to consult on this patient, but before we saw the patient was actually evaluated by the ward team, and in particular by one of our medicine chief residents, Dr. Cedeno. Dr. Cedeno is on with us today, and because he's more familiar with the case, I thought we might want to go ahead and give him the chance to give us about maybe a 3-minute summary of this. One of my other residents who worked with me this week, Dr. Sidhu, can also fill in some of the details about the somewhat subtle neurologic issues with this patient. So if you can let Dr. Cedeno on.
Hi, Dr. Birnbaum. Hi, Dr. Vohra.
Great.
Thank you for having me on. So yeah, I'm currently on the ID service here at St. Agnes, and we were consulted for a patient who already seemed to have the established diagnosis of neurosyphilis, but essentially how he got here, he's a 53-year-old male, has a history of developmental delay. And so at baseline, from what I'm told by talking to his niece, he's able to perform all his ADLs. He's, for the most part, otherwise independent. But over the past 3 or 4 days prior to admission, he was having a change in behavior that's not known to them. He was appeared more anxious, apparently was having some hallucinations, and just an overall change in demeanor that they thought was different from his norm. And so the night prior, he was a little bit more anxious than usual, and so he was admitted to the hospital for encephalopathy. And they were admitted to our family practice medicine team. And so in the workup, they did get an RPR as part of encephalopathy workup, and his RPR titer came back 1 to 128. And so this essentially, triggered, on top of his encephalopathic presentation warranted a lumbar puncture. And so essentially the most widely accepted definition for neurosyphilis is having a positive non-trypanosome CSF test. And so his CSF VDRL did come back reactive at 1 to 8. And so that helped essentially confirm. Now, on physical exam and examining the patient, he really was, for the most part, nonverbal. It's hard to communicate with him. He didn't really give us any symptoms or history. And so a lot of the history that we obtained was from the niece. At presentation, he didn't have any rash or any of the other typical symptoms of a primary or secondary infection. And so we're left at essentially what I'm thinking is maybe asymptomatic neurosyphilis type picture. In terms of other history, it seems he was born here actually in Texas, but has lived in California and Fresno for most of his life. Again, he was more or less independent up until, from at least 2000 to 2017, he was living on his own with a roommate who had been male. And per the niece, he was sexually active or presumed sexually active with this roommate. It wasn't until 2017 where he started living with his niece. And so where we are today is we started treatment for neurosyphilis with penicillin, penicillin G, 4 million units, Q4 hours. And given his underlying developmental delay and concern about compliance with the frequency of penicillin required for treating the infection, we made the decision, or the primary team made a decision, to keep him here in the hospital to complete his course of penicillin.
Very good. Maybe we can have Dr. Sidhu, who also should be on the call, give us just a few words about what he and I saw on the patient when we examined the patient the other day relative to cognitive issues and some interesting but fairly subtle neurologic findings.
Definitely. Hi, Dr. Vohra. Hi, everyone. I'm Ramit. I'm one of the second-year residents working with Dr. Birnbaum. Yeah, this was definitely an interesting case for us to see, particularly because the patient had a history of intellectual disability, and we weren't really sure of his exact cognitive disturbance when we had gone to see him. But kind of starting out with a formal neurological exam, when we went to go see him, his general appearance seemed well nourished. He was a 53-year-old male sitting at the edge of the bed. When we assessed his mental status, he was orientated to purse, but he was not orientated to place or time. He gave us the wrong month, but gave us the right year, but could not really tell us where he was. It was, like I said, it was a little bit difficult physical exam because of his intellectual disability. So we were going to assess the memory calculation and abstraction parts of the memory exam, but those were very difficult to assess. But to say the least, they would be moderately impaired if we were to pursue them. And then the language part of his exam, he spoke English. He showed understanding. He was expressive and receptive to the information that we were saying, but he did on notes speak in very short 3 to 4 words instead of fluent sentences. That's what we noticed when he was trying to express himself. In terms of cranial nerve exams, in the beginning, when we saw his eyes, they were minimally reactive and bilateral pinpoint pupils. That's something interesting that we saw. And then when we further assessed the third cranial nerve exam, during the H test, we noticed that he had some nystagmus on conjugate gaze on the right side, which we kind of thought he could have a component of partial internuclear ophthalmoplegia because he had some, nystagmus only on the right side. So that was pretty interesting to see. But other than that, the remaining cranial nerve exam was primarily negative. And then moving on to the motor exam, we suspected with a patient with neurosyphilis to have no abnormal motor exams. He was 5 out of 5 in power in the upper and lower extremities, so no abnormalities that we elicited there. In terms of reflexes, his brachioradial and patella were very brisk in the left and right side. Actually, just lightly tapping on to assess for reflexes was very prominent. So that was kind of interesting, and it was good practice to see that on a patient with such brisk reflexes. And surprisingly, you know, with the history of when he might have contracted syphilis, we were suspecting to see some sensory abnormalities, but surprisingly, he didn't. It was normal throughout, and he didn't report of any paresthesias or shooting pains as well. So that was kind of something that we were expecting to see, but we didn't see. And then moving on to the coordination and gait part of the exam, interestingly, when we did the finger to nose test, he showed some dysmetria on the right side, but not the left side. So the right side was very prominent to show dysmetria, but left side was normal. We had him walk around the room. He had normal gait and balance, but something, I mean, you know, kind of something we noticed that he kept his arms by his side. He didn't have any swaying of his arms. They were right next to his sides, and he didn't move them at all. So that was kind of interesting. And his Romberg was negative. We thought he would have a little bit of a positive Romberg sign, but that was also negative. And then to conclude that exam, he was able to sit from standing position and stand from sitting position. And then the last part of the exam was his psychiatric exam. The one thing that we did notice is throughout the entire exam, he had somewhat of an abnormal affect. He remained kind of his facial expression remained the exact same throughout the entire exam and didn't change at all. So that was kind of interesting to see as well. But he was pretty cooperative and calm and didn't have any hallucinations or anything like that throughout the psych exam. But that was something interesting to see, and that wrapped up kind of our neuro exam to whatever extent that we could. But we didn't notice any sort of long-term, you know, dementia type things or any skin lesions or any, you know, anything of that sort.
What I can add to that is clearly for us to assess this gentleman relative to cognition, this is made difficult by the fact that he had a pre-existing developmental disability. Relative to the additional evaluation that the ward team had already completed on the spinal fluid examination, the man did have a pleocytosis. I believe he had about 53 white cells, almost all of which were lymphocytes. And while his glucose was normal, it was about 65, he had a substantially elevated protein, I believe in the 160 range, which is at least 4 times elevated. So it was very interesting for me to see this sort of case. I must admit that having practiced neurology in Fresno for now 42 years, I don't think I had seen a prior case of CNS neurosyphilis. Although very interestingly, as Dr. Sidhu and myself were discussing the case initially, adjacent to us was one of our fine gastroenterologists, Vivek Mittal, who had done some training in India at All India, which is the great medical school in New Delhi. And he said, what's the big deal? We saw these cases all the time in New Delhi. So what's an unusual case here in New Delhi due to different public health standards is not.
Well, they don't see a lot of meth in New Delhi, so there you go.
They're lucky on that. We see too much.
So when is this guy going to get better? I mean, you said he's on penicillin. I mean, what's the prognosis here?
Well, I'm not quite sure. They're going to finish his course of treatment. And then I believe the recommendations, just quoting from Dr. Cedeno's a very nice evaluation. This is someone who should be followed clinically and then probably needs a follow-up tap to make sure that this is quiescent in, I think, 3 to 6 months. At that point in time, you know, he might still have a positive VDRL in the CSF. That may never go away. But certainly we would, by that point in time, you'd like to see his protein back into the normal range and no further pleocytosis.
Can I make a comment, please? This is Nail Nassar.
Yes. Hi, Dr. Nassar, please.
How are you?
Please. Good.
We see actually a sizable population of neurosyphilis at community hospital, especially in HIV patients. So, you know, it's not a rare finding in Fresno, but since my population is more biased toward the HIV population with increased risk of transmission of syphilis, especially in men who have sex with men. So actually, it's not an infrequent thing that we see it in community. And actually, I am the one who consulted in the case that's right now at St. Agnes.
Happy to have you come on and comment further. Really appreciate it.
Thank you.
What do you make of the the asymmetry, was there anything on the imaging? Like, as I recall from medical school, like there's gammas that can happen in the brain. And so is there anything on MRI or the imaging that showed a localizing or focalizing lesion?
No, there was nothing. And yeah, both CT and which were red.
Interesting.
It's the same thing on HIV. Usually we do not see much on imaging.
Okay.
You know, that patient that's being presented now is a little bit different because we could not obtain any history from him. And his titer for RPR was 128, which is usually higher than what we see in neurosyphilis that just happened with a disease that hasn't been treated for years, and now it pops up. I think some of these people have syphilitic meningitis, which you know, which dwell much faster. It's a part of the you know, of the early manifestations of syphilis. Recommendation is to treat it as neurosyphilis. But this guy, we could not get any history of pain, neck stiffness, you know, anything at all.
So a disease we would like to think to be extinct is far, far from extinct.
It's alive and well.
Yeah, and please read that NPR, or please listen to the NPR story or read the ProPublica article, because they really, you know, it's about Fresno, and it's an embarrassing thing they get national exposure for, but you know, here we are. This is our patient population, and we need to be on the lookout and be very aggressive about treating people, getting their partners treated and screened, and definitely trying to prevent congenital syphilis, which is so tragic. Any other questions or comments? Thank you, Dr. Birnbaum, Ramit, Dr. Sedano, Dr. Nassar. This was great.
Great seeing you.
Thank you for having us.
All right. I don't really have any other prepared topics, but I'm happy to open up for a roundtable or open conversation if anybody has any questions or concerns.
Dr. Vohra, this is Julie with Central Valley Indian Health.
Hi.
How are you today?
Good. How are you, Julie?
Good. Just a quick question I've thrown in the chat, but I wanted to ask, our staff are wanting to do away with the daily COVID screenings. What are your thoughts on that?
Yeah, you know, I think it kind of depends on what you mean by the daily screening. I think on the one hand, it is that it is kind of a pause and reminder to people, like, don't come to work sick. You know, if you have any symptoms at all, or if you had a close contact, you know, you live with a relative that has COVID, really think about taking that extra step to either stay home, or if you can't stay home, go get tested, so that we can continue our operations without endangering the rest of the staff. So there's some definite benefits to it. If you do away with it, I think you'll have to think through, you know, how you can capture those benefits with other formats, whether if they're doing an online screen every day, then certainly that would be acceptable. If there's some other way for you to do, you know, either a group huddle at the start of the shift or some other process to really ensure that people aren't spreading illness in your organization. I think that's the real spirit, if not the letter of the rule. So you know, I'm happy to advise about what you want to come up with as a process. But I think, you know, it needs to be clear to all of your staff that if you do away with the daily screening, that doesn't let them off the hook, because they still are, you know, responsible for each other's safety and for your patient's safety. And they need to really take these extra steps, especially if they're not vaccinated, to ensure that they don't have COVID themselves and that they're not spreading it through symptoms.
Yeah. Okay. I mean, and that's honestly my thoughts as well, because I really felt without the screening that people just came to work still.
Well, I mean, I don't think I don't think all hospitals are doing daily face-to-face screenings anymore. So I think online format is okay to do. I just, I would just say, think about the context and think about the culture of your organization and what would work.
I appreciate your input. Thank you.
Sure. Good question. Thank you. All right. If there's no other questions or comments, thank you all. This was a really enlightening meeting. And like I said, we continue to help support those of you who need our help with monoclonal antibodies, with getting established as vaccine providers, which we really hope a lot of you can do if you haven't already, just because we do need, a lot more doors for our kids to walk through, and really a lot more providers just talking to patients. Even if you're not providing vaccines, at least have those conversations with your patients, regardless of what your specialty is. As a professional, your opinion counts so heavily in their decisions. And we really hope that you can convince our community to really accept vaccines at a higher rate. That's what we need, even at this late stage of the pandemic. And thirdly, please, care for yourselves and care for your staff from a mental health standpoint. We're hearing from a lot of different corners about the level of fatigue, exhaustion, and burnout that people are dealing with. I think that's real. I think that's something that we do need to be sensitive about, especially if we are starting into a winter surge. That's only going to make things worse. So please think about, especially if you're in a leadership position, think about how you can support your staff and really encourage resilience and wellness activities, and take care of yourselves as well. We'll be back next week with more updates. If you have any other questions, let us know, okay? Thank you.